The American healthcare system, an issue under so much political and economic debate that the heart of the problem has almost been forgotten: the patients. Quality of care is appearing to become less and less important, especially for those who are not in America's majority groups. Take, for example, Francisco Torres. In 2010, the Spanish-speaking man was admitted to a California hospital for kidney disease and handed an informed consent form for which he was supposed to sign off on the removal of his diseased kidney. However, the form was in English and there were no interpreters provided to him, so Mr. Torres could not tell that he was agreeing to the removal of the wrong kidney. After surgery, Torres' doctor realized the mistake and removed the diseased kidney, leaving poor Mr. Torres with no kidneys left. Cases like Mr. Torres's are not isolated and occur throughout America. While the U.S. is a primarily English-speaking country, Spanish is the second most common language nationwide, with over 40 million speakers as of 2016. Unfortunately, though, even with federal laws advocating on their behalf, limited English proficient, or LEP, patients often receive subpar care due to a lack of communication. So what is this informed consent that cost Mr. Torres his kidney? Informed consent, or IC, is a cornerstone of the American healthcare system and is enforced wherever medicine is practiced. It is the role of the physician to clearly state what the proposed medical procedure entails, and it is the role of the patient, or if incapacitated, a relative, to sign off on it. However, if the patient and doctor do not speak the same language, it becomes difficult both to inform and to give consent. Moreover, the documentation to be signed is almost always in English, regardless of the patient's language of literacy. So now we can ask our question: to what extent does the race and primary language of the majority of nurses and doctors and the growth of Spanish speakers nationwide lead to a diminished quality of medical care for Spanish-speaking patients and strip them of their right to informed consent to medical procedures? Let's cover some basic facts. As of 2015, only 5% of medical school graduates in the United States were Hispanic or Latinx. This number stands in startling contrast to the percentage of American citizens of Hispanic or Latinx descent in 2015, 18%, more than triple the number of Hispanic or Latinx physicians. What's more, the Latinx population has accounted for a staggering half of the U.S. population growth since 2000 and is the second greatest racial or ethnic group in the U.S. behind whites. However, the likelihood of a Latinx person walking into an American hospital is 3 times greater than the likelihood that he or she will be greeted by a doctor who shares his or her culture and primary language. Further, Hispanic and Latinx people have the highest uninsured rates of any ethnic or racial group in America, making it even more difficult for them to receive medical care, let alone that of quality. So now we're going to try to show that the root of the disparity in quality of care among Spanish-speaking patients and their English-speaking counterparts is the lack of diversity among physician populations, paired with the growing diversity throughout the nation. We will see the importance and necessity of linguistic and cultural communication in providing adequate medical care, thus demonstrating the fact that the disproportionate number of Latinx doctors to the American Latinx population leads to a diminished quality of care among Spanish-speaking patients in American hospitals. First, let's look at a study by Helen Tarp, a professor in Idaho, who found that not only are many physicians not given the resources they need to properly treat their LEP patients, a startling amount of them are not even aware of the resources that they should be entitled to, leaving not only patients but their doctors as well in a helpless situation. For example, interpreters are an extremely useful tool that are not often made available to LEP patients. Stephen Malushin, a professor at Dartmouth, states that rather than employing trained medical interpreters, hospitals often rely on 3 main forms of communication. 1, their own language skills, 2, the skills of family or friends, and 3, ad hoc interpreters, which refers to Spanish-speaking patients from the waiting room, other hospital employees, medical or non-medical, and more. With such a lack of quality interpretation, often doctors are not accurately informed on the patient's condition, and patients are not fully made aware of their treatment options. Such a lack of communication causes complete informed consent to become nearly impossible to attain. While this seems obvious, the majority of hospitals still do not have trained interpreters, if any at all, on their staff. Malushin acknowledges the fact that trained medical interpreters can be expensive, but he outlines the federal laws that were put in place to make sure LEP patients are given the quality of care they deserve. He discusses the Civil Rights Act of 1964 and how it declares that there will be no discrimination based on race, ethnicity, gender, etc., which was expanded to include language differences. However, there were no set guidelines dictating how to make sure discrimination was to be avoided when it comes to language. This problem was addressed again in President Bill Clinton's 2000 Executive Order 13166, which stated that medical settings must provide language access to all patients. Though, just like the Civil Rights Act, what was meant by language access was not explicitly stated, and most physicians did not make noticeable changes to the ways in which they provided care. While these laws should make the use of highly trained medical interpreters mandatory, they unfortunately do not, and the majority of LEP patients suffer the consequences. But it's not just linguistic challenges that increase the gap between patient and physician. Cultural differences also hinder the treatment process. Each ethnicity has their way of dealing with illness and their own relationship with medicine in general. In South America specifically, traditional medical practices are relied upon and widely accepted by Latinx people, with the practice of medicine becoming a more social process than Westerners are used to. It is a uniquely Western belief that science should be detached from human interaction, leading medical patients to be seen more like subjects. Physicians who treat Latinx patients just like their American ones are not providing adequate care. Furthermore, some common illnesses in North America are not the same as those affecting Latinx people. Due to a lack of cross-cultural training, physicians will often examine a Latinx patient in exactly the same fashion as an American patient, overlooking the symptoms that plague South American residents, but they do not normally see in their regular practices. Without proper cultural translators, many of these diseases go completely undiagnosed and untreated. This phenomenon was exemplified in the case of Willie Ramirez, an 18-year-old boy whose family brought him to the hospital for headaches and nausea. The family used the Spanish word intoxicado, which in Cuban culture is not specifically used to describe drug-related intoxication, but rather used to explain any ailment that has to do with something that one eats or drinks. However, this was not translated across cultures, and Ramirez was treated for a drug overdose for 4 days instead of a brain hemorrhage, leading him to unnecessarily become quadriplegic. While it appears evident that resources should be provided for the improvement of quality of care to LEP patients, the majority of healthcare providers, especially hospitals, remain reluctant. In fact, there exists a California hospital with 7 Spanish-English interpreters for an average LEP patient population of 33,000. There is rarely a training requirement for interpreters and minimal requirements, with no training for physicians regarding the use of interpreters in their appointments. With such a clear link between linguistic and cultural gaps and diminished quality of care, the fact that medical interpreters are rarely considered, let alone used, is anomalous. In a study performed by Yael Schechner, it was found that LEP patients are almost half as likely to be provided with informed consent documentation in direct violation of the law. Speaking of law breaking, the use of ad hoc interpreters we described before violates the HIPAA law, allowing complete strangers to become privy to patients' medical information. Now, some people may attribute the disparity in quality of care to the lack of funds in many hospitals, especially public ones. While hospital budgets are often extremely tight, it is a conscious decision on the part of the administration to allocate the majority of resources towards the maintenance of care of English-speaking patients. While financial factors may play a role in the diminished quality of care of LEP patients, they do not undermine the fact that there are still more than 3 times as many Spanish speakers in America than there are Spanish-speaking doctors, leading to the conclusion that it is, as originally stated, a demographic issue, which leads to the gap in medical care. Ultimately, doctors need to take the initiative to improve their cultural and linguistic diversity, and hospitals must learn to understand that money spent towards interpreters for LEP patients is money well spent. If no changes are made, there is an increased possibility of a spike in diseases that disproportionately affect Latinx patients, such as obesity and high blood pressure. Francisco Torres would still have his kidneys if IC documentation had been in his native language, and Willie Ramirez would still be able to walk if linguistic and cultural interpreters had been available to translate between his parents and doctors. No longer can Spanish-speaking individuals be denied adequate health care and stripped of their right to informed consent simply because they cannot be understood.